this ECG section, I'd say is pretty epic, really. Like we're gonna go through so much stuff, and also the stuff that again, Meg did some great work here, especially with her own experience with the exams. They go through some really niche things that I think if you know, if you know what you're looking for, it's great, and it really hopefully gets you in good stead for this exam. So take it over, Meg.
So in terms of ECGs, I am by no means an ECG expert. I found learning ECGs for the exam quite stressful and certainly at times quite difficult. So I'm sure there will be a couple of you in the group who know more about ECGs than I do. So if I say anything wrong or if there's anything that I've missed out that's like a key sort of knowledge point in someone's mind, please do share it. The preparation that I did was definitely Lahiru's investigations sort of course, which I think is really great. But also Life in the Fast Lane, going through the ECGs on Life in the Fast Lane. So there'd be days where like for an hour, for 2 hours, I just go through ECGs on Life in the Fast Lane and try and relate them to conditions that I thought could come up in the vivas as well, and focus on those key findings. So, like right heart strain, LVH, left heart strain signs, arrhythmias, blocks, all of those kind of things can definitely come up and be related to a condition that you could get in a med viva or in an anaesthetic viva. And I certainly got lots of ECGs in the exam, so I'm glad that I went through that. A lot of the ECGs that we are showing you today come from Life in the Fast Lane, so we just want to credit them, and definitely a plug for their resources as well, as I just said. When you're faced with an ECG, other than saying what the key abnormality is, what's your structure for going through an ECG?
I go rate, rhythm, axis, QRS breadth. And then I comment on the ST segment, the T waves, and then R wave progression.
Really nice. Do you have a similar method? Do you have a different method?
Yes, same method, but I just do PR before QRS.
Yeah, great. I think, as long as you have a method, as long as it makes sense to you, and as long as it covers the key things, which, both of you definitely do, then, that's great. So, I agree. Rate, rhythm, axis, hypertrophy, waves and intervals, and checking for signs of ischemia, whether it be new or old as well, can be really helpful. I'm really glad that Lahiru taught me this method in terms of calculating the rate, because I was doing the multiplied by 6 method, which I think, or divide by 300, which I think in the stress of a viva can be really, really difficult. So another way to do it is to go to count the big squares. So you essentially go 300, 150, 100. This would be 75. It's a little bit faster than 75. It's about 80. So unless it's really, really slow, that's a nice way, I think, to do it. I know that's a quick explanation. Does that make sense to the majority of people? Does someone give me a thumbs up? Okay, thank you very much.
Question about the rate.
Yeah.
Your irregular rate, what's the best way to calculate that?
I think everyone does it differently. I decided that in the viva, I was going to pick the bit that looked the fastest, pick the bit that looked the slowest, calculate both of them using the 300, 150, 100, and then say the rate varies between X and Y.
Thank you.
If the rate's really slow, take the 10-second strip, QRS complexes times 6, because it's going to be faster than going 300, 150, 100. How do you determine the cardiac axis?
So cardiac axis, you can start by looking at lead 1 to see if the QRS is more positive or not. And then if it is positive, you can look at lead 2. And if they're both positive, then it's a normal axis. And if lead 2 is negative, then it's left axis deviation. And if 1 is negative, then you can look at AVF and calculate from there for right axis.
Nice. Yeah, that's a method that I've definitely heard and I know works for lots and lots of people and sounds perfect. It's not one that I used. Just question with your method, is there a way of giving like the exact number, like saying the axis is negative 30 or something?
No, that's something I've got to put a bit more effort into. It's just like which direction.
Okay. So what I did was I divided it into a screening method to screen for deviations. And then if it was deviated, then I calculated the exact number if I thought it was relevant to the overall presentation or if I was asked. So my screening method, and I'm sure like every cardiologist is going to, you know, roll over their grave, but it's what I call the thumb method. So your left thumb is lead 1, your right thumb is AVF. If they're both up, you're all good. It's a normal axis. If one is up and AVF is down, then it's a left axis deviation because it's deviating towards your left thumb. If one is down and AVF is up, then it's a right axis deviation. And then in terms of my precise method, I use the isoelectric lead method. Volunteer, is anyone familiar with the isoelectric lead method and wanting to explain it?
I think this might be the one that I use, where you identify out of those left-hand 6 leads, you identify which one's the isoelectric lead, and then you identify the one that's the most positive, and then it's 90 degrees between, like, from the isoelectric lead in the direction of the most positive one.
Yeah, absolutely perfect. What is the axis for this one?
So just screening it, it looks like a normal axis initially. And then if you look at the most isoelectric between 2, 3 and AVF, I'd probably say that is AVL. And then I'd have to draw the little thing, which I probably can't do off the top of my head, and just go 90 degrees.
Yep.
Yeah, so you go 90 degrees from AVL, which would be somewhere in that normal range on the right-hand side. So probably about plus 60.
Yeah, perfect. Sorry, I was going to make a point as you were saying something, and now it's gone out of my head. But exactly what you said. So isoelectric lead, positive in AVF. Thus, you can just add 90. So negative 30 plus 90 is 60. What I was going to say, sorry, it has popped back into my head. And then you can screen backwards. So you screen with the thumbs, and then you can screen backwards and go, yep, that makes sense because I said the axis was all good. And I've got positive 60. That's in the all good zone. Everything makes sense and goes together. What's the axis?
So here there's negative in lead 1 and a positive in lead AVF. So I think it's a right axis deviation. Is that right?
Yes.
And then the exact axis. So I think the lead 2 looks like it's the most isoelectric. And so lead 2 will have to be, hang on, sorry, I'm trying to figure out in my mind.
Okay, I will make it easier for you again and go to the next slide, where we have the little circle thingy.
Yep. So 90 degrees, it would be 60 plus 90, which is about 140 degrees, because it's in the right side in that green quadrant.
Yeah, I agree with you. And then screening backwards is consistent with right axis deviation. So good. Did you want to give a go at this one?
So just taking a look at it for a second, it would be negative, I don't know, it's like negative in 1 and in AVF.
Yeah, it's really hard, isn't it? But I agree with you. Yeah. Which is an extreme axis.
Yeah. In terms of the isoelectric lead, I don't know, it's difficult to tell. I guess if I was taking a guess, I would say it was AVL. And then the most positive one then would be AVR. So that would be about minus 120.
Yeah.
So right axis deviation.
I agree with you. I think this one's really hard, but I agree with everything that you've said. And we sort of on the screening method, it was negative in both, which we know is an extreme axis deviation, so part of the reason I included this is just to open the question of how do you tell the difference between SVT with aberrancy and VT, which we'll come to in more detail later, and seems to be a favoured question in terms of previous vivas, but in terms of also previous SAQs. Because an extreme axis deviation helps you think that maybe this is VT, although there's lots of other features to go through. So let's do some cases. So we've got a patient here, post-intubation ECG, young adult presenting with coma following a 6-gram quetiapine overdose. I'll ask for a volunteer here who wants to talk about this.
Sure, I'll give it a go. So it appears to be a sinus rhythm. It's a rate of around 150, and it's regular. The PR interval looks, I'm going through it systematically because I can't see any immediate abnormality when I'm looking at it, but the PR interval appears to be normal. The QRS complex is within normal limits in terms of its width. I can't, there it appears to be just sort of maybe some ST depression. No, I think it's just the T wave. So I would say it's a sinus tachycardia. I think with quetiapine overdose, I'd be looking to see if there was a prolonged QT. It's difficult because I can't really see the T waves.
Yeah, so you're exactly right. So it is actually a prolonged QT. Also, your systematic review, everything you said was correct and in a well-structured order. And then if you can't see an abnormality and you're expecting to see a specific abnormality, I think it's entirely reasonable to do exactly what, actually probably perfect to do exactly what Amy did and say, I'd expect to see this. It maybe is there, but it's a bit difficult to see, or it's a pertinent negative that I'm not seeing it. But you're actually right. So this is a prolonged QT. I think with the eye of faith, you can kind of see that maybe the T wave sort of finishes there, maybe sort of ish here. And as a general rule, just in terms of a screening method, if it's more than half, if the QT interval is more than half of the preceding IR interval, then it is probably prolonged. Because you're not going to get, so you're not going to calculate probably an exact QT in the Viva. And then I agree with what you said about the axis, and then the obvious abnormality is the QT interval. How do you calculate the QT interval?
Okay, so the QT interval is. I've just forgotten. I'm just drawing a blank on the formula. Is it the RR interval, the RR divided by the square root? Hang on.
So that's the QTC. Just
Yep.
how do you determine what the QT is? It's the start.
So the QT interval is the start of the Q wave to the end of the T wave.
Yep.
So normal values. So for a male, it's about 460. For a female, a bit longer, 470. A rule of thumb I use is it should be half or less than half of the RR interval, and it varies with rate.
Yeah. So the numbers that I have are, sorry, I'm just checking the message. The numbers that I have in my mind would be slightly different to yours, but the direction you had is absolutely correct. That women the QT tends to be a little bit longer, and what you said about calculating the QT interval is absolutely correct. So 440 in men, 460 in women. Excuse my being maybe slightly politically incorrect, but I remember it as the sixes have more curves than fours, and in general, women have more curves than men. And more than 500 is associated with a significant increase in risk in torsades. And your calculation was good too. So I think you were talking about the percent formula. So it's QT divided by the square root of the RR interval. You're absolutely right. So this one's a 61-year-old lady who's brought in by ambulance with palpitations and dizziness. And these are her vitals. What do you reckon?
Okay, so this is a 12-lead ECG. The most abnormal finding is that irregular complex tachycardia. It has a right axis deviation. The rate, it has the rate says up there 190, but it has a high ventricular rate. So the ventricular rate is about 300. So it looks like a atrial fibrillation with something else, maybe an some accessory pathway.
Yeah. So like AF with aberrancy, right? So let's just go through it systematically. Your differential diagnosis. So you've got a broad complex tachycardia. So I mean, it doesn't really look like it, but I guess VT could be a possibility. Or something else with aberrancy, right? Your treatment in this circumstance, did you want to volunteer what you think, given that this patient's hypotensive, 75 on 50, what do you think you'd do with this rhythm?
The CCV.
Yeah, perfect. Yeah, so electricity. So I think it's actually about 150, not 300. I think maybe you were doing 300.
I was just looking at ventricular rate.
Yeah. Did anyone else want to comment on the rate? I think it's closer to 150 than it is 300.
I was getting 300 as well, but
Were you? Maybe that's a mistake on my behalf.
and I'm not sure.
If I look at the fastest point, just in, let's say, lead V1, it looks like it's almost 300, but then the slowest point is close to 120 or so.
Oh, okay. Yep. Apologies, guys.
Can you comment that there's a variable rate? Variable rate from 100 to 150 to 300.
Yeah, I think that's probably better. But also you were quite right, and I was wrong. It's irregular, which I think is well you said. So AF with aberrancy versus something else. And then we talked about drugs versus electricity, and you're absolutely right. So favors a zap. So this patient gets cardioverted with revision to normal sinus rhythm and resolution of the hemodynamic abnormalities. And then we've got this ECG for someone else to have a comment on.
Obvious citation indicated by the delta waves, but my systematic approach is that the rate is just under 100. It is a sinus rhythm. There is a P wave for every QRS, and the PR interval is normal. There is a mildly widened QRS complex. The ST segments are normal throughout. Sorry, I should have commented on the access. It's normal access, and there's no lengthening of the QTC. So in summary, this is some indication of a preexcitation syndrome, perhaps Wolff-Parkinson-White.
Yeah, perfect. I really like that interpretation. Bringing it back to a Viva situation, I think you could have added, because you've nailed the diagnosis, you could have added, and therefore it's not unsurprising that this patient has had a period of rapid AF, as it's common in patients with pre-excitation syndromes, just to really bring it back to the whole case and tell the story of the Viva. But I 100% agree with everything else, with everything you said. We've got a patient that you're going to see off the tow list. Cardiology Reg has just added them. They're presented to ED 2 hours ago with shortness of breath.
I'll start by commenting on 12-lead ECG. The rate appears to be about 150 beats per minute. I don't see an obvious P wave in this in the lead 2. The axis appears to be a left axis deviation, and I can see that there is quite a deep S waves in V2 to V4. My working diagnosis based on the absent P wave and the rate would be an patient is in SVT.
Yeah, definitely a reasonable diagnosis. Another lead that's often good to look for P waves or look for atrial activity is V1 when you think you can't see something in lead 2. Did you have any thoughts on what these little things were here?
Yeah, so it looks like there are P waves, but not all of them have a QRS complex following the P waves.
Is there anything other than P waves that they could be, given that the patient's in a rapid rhythm?
It's the rate is also irregular in V1.
Yeah, so I actually reckon this is probably flutter, and that those are probably flutter waves. Did anyone else have any thoughts about that, or any other differentials, and maybe variable block to explain the periods of irregularity? But I agree with absolutely everything you've said, especially your comment on the left axis and the sort of which signal of chamber enlargement here. And then just to tie it back to a patient with amyloid disease, they often do get arrhythmias. And because of the infiltration of the amyloid into the left ventricular wall, they often will have a left axis deviation and meet sort of criteria for your typical LVH, although it's not technically hypertrophy, it's wall thickness increase. Just to tie it back to the patient, that you've got presented in front of you. We've got an ECG of a 76-year-old woman in the PACU after a knee replacement. She's got lots of cardiovascular risk factors, and then outline your initial management and develop a plan in the event of this rhythm disturbance that's presenting. What do you think this is?
Yes, so this is irregular rhythm. Baseline, there is AF without obvious P wave, and the otherwise very deep S wave in V2, and the peaked T wave in V2 as well. So those are, I think, strain pattern of left ventricular hypertrophy.
Yeah, okay. I definitely agree with you that it's rapid AF. Did you want to comment on the rate at all? I think you may have said something about it being quick.
So yeah, this is rapid AF rate is between 100 and 150, so 130, but it's irregular.
Yeah, it's irregular, so it's a little bit difficult.
Intermediate axis.
Yeah.
Yeah, that's a summary.
And let's imagine for a moment that you were in a Viva and you've got a patient who's, got cardiovascular risk factors and you've just done a knee replacement. And then because nothing ever goes right in a Viva, the patient goes into rapid AF after having previously been in sinus. So you've interpreted the ECG and you say, yeah, this is rapid AF. And you're asked what you're going to do about it. What do you reckon you'd say?
So I will say this is stable or unstable. So I will look for the blood pressure or any signs of symptoms. If there is, I would like to prioritize treating this RBAF. So DC, I will consult with a cardiologist for DC conversion. So
yeah, you could even do it yourself right there in PACU if she was unstable. They've certainly asked questions in the past where they ask you how you would cardiovert someone, and they asked me that in one of my Vivas as well. So yeah, in management, it depends on the hemodynamics, drugs versus electricity. If they're unstable, give them a zap. Yeah, agree with you on everything else. Can you describe this ECG?
Yes, so this is a ECG with a rate of 150. The axis appears normal. Can't distinguish any P waves before the QRS. Narrow complex QRS and QT about half of the RR interval. Overall, I think this is maybe some type of SVT, probably AV-NRT. Is my suspicion, with the P wave hidden somewhere in the complex.
Yeah, nice. So there's no P wave, it's a narrow complex. I've just got that it's typical SVT. If you're able to differentiate AV-NRT from SVT, from typical SVT, I'm super impressed, and we'll have to hunt you down to teach me how to do that later. But I agree with everything else that you've said. There's no visible P waves, but it's a narrow complex. There's got to be something like an SVT going on. Then I'm going to ask.
He's making it up, Megan. Sorry, just to clarify.
Oh, okay. I don't have to be too intimidated. What do you think of this one?
Looking at this, we've got a left axis deviation, maybe borderline left axis. There's quite pronounced ST depression throughout, with ST elevation in AR. So I'd like a history, but I'm feeling like I'm concerned about left main occlusion.
Oh, okay. What did you think of the rhythm?
The rhythm, it appears regular but quite quick. So SVT.
Yeah, can you see any P waves?
No, I can't see any.
Yeah, no, I couldn't either. Do you reckon it's a narrow complex, broad complex?
Narrow.
Yep, I agree. And just go back to the axis for me. I reckon it's up in 1 and AVF.
I felt like 1 was the tricky one.
Yeah.
Whether that was kind of up or just borderline down, I wasn't sure.
Oh, okay. All right. If it was down, what axis would that make it?
That would make it left. That's right.
Yeah. Cool. So I see what you're meaning about the T waves. So this is actually AV and RT, as we were talking about just before. So yeah, agree, narrow complex tachycardia, super quick, no P waves. There is this thing, I mean, look, Lahira and I had this discussion offline a couple of days ago. Do you need to be able to differentiate, garden variety SVT from AV and RT? Probably not. But if you were looking for what those criteria were, it is pretty common to have this widespread ST depression in AV and RT apparently, which I only learnt after the exam whilst making this ECG talk. Again, this is not one really that you have to know either, but sort of here for completeness of the discussion of SVT and for the gunners amongst the group, if you've got this sort of weird retrograde P waves after the QRS complex, it's something called slow fast AVNRT, but that's sort of like a micro point amongst all of the SVT talk. I'm going to ask a 12-lead ECG, 68-year-old post-anesthetic care unit, hip replacement. Try and think of this as a Viva. I know we're all past the SAQ stage at this point. So interpret the ECG, give us a couple of causes and tell us what your management would be.
So looking at the ECG, the rate is about 150. The rhythm, so it's a broad complex tachycardia. The axis, it's difficult. Let's say difficult to determine. We see that AVF is up, and 1 is sort of indeterminate. No P waves are present. So it looks unless so there may be P waves that are hidden, but I would presume that this is a ventricular rate. So my differential for this would be VT, although it could be SVT with aberrancy. It's my second. So likely causes of this rhythm disturbance, given the history that we've been given. So this is a patient that may have had an ischemic event, a coronary event, or an electrolyte disturbance, and then appropriate management for this. So first, I would want to check the other vital signs, especially the blood pressure, assess them if they're in hemodynamic shock, and that would make an immediate decision about whether we would need to consider immediate cardioversion. I would be looking at other teams that are involved, so cardiology, for example, and then taking a full set of bloods, looking at if there's any electrolytes that need to be optimized, and any potential causes for that as well. And that would, again, be guided by the acuity of the situation.
Yeah, really good answer. I agree that it's a little bit hard to find to determine exactly what the axis is, but I think this is probably upright and this is probably upright as well. And then you could maybe say that this is the closest to the isoelectric lead and calculate from there. But it is always sort of difficult with these sort of really weird and bizarre complexes. I think that in a Viva, you could probably say, look, it's, VT is a thing, it's VT until proven otherwise. It's a regular broad complex tachycardia. SVT with aberrancy is a differential, exactly as you said, but just sort of, make the examiner know that, VT is, we've got to presume that it's that. And then we'll talk later in the Viva about ways to differentiate SVT.
Now, what's new with AV Students Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.